So neurohormonal modification in ACHD versus heart failure. So the question is, and something that's been brought up, and I will go at it a slightly different way with some overlap, should we use medications for neurohormonal modification in adults with CHD that have been proven to benefit adults with other forms of heart failure and systolic dysfunction? Caveats: I won't try to define heart failure and ACHD. As we've seen, it's hard. I'll be vague about what I mean by heart failure, comparable to acquired heart failure with a reduced ejection fraction, assuming we agree, but knowing that we disagree. We'll be thinking about together different lesions and situations where there is debate in your mind. And I won't present much data on therapies in ACHD heart failure. There have been a bunch of valiant efforts. As you just saw, the Swiss are making another valiant effort, and these studies have been useful, but they don't really answer our question. So first I'll start out with a case. So Mr. Wright is a 44-year-old man with detransposition. He had a mustard. His MRI EF was 33%, has a GFR of 75. He's functional class 2 with a peak VO2 of 68%. He has no volume retention, and you look back, he's been lost to follow-up for 6 years, and he had exactly the same values 6 years ago. So now, though, you're seeing him, and what's your goal medication regimen? So how many people, A, let the poor man be? Okay, nihilists, please, please. B, beta blocker alone. C, ACE inhibitor alone. Now, it's a little confusing. New York Code Association functional class 2, I didn't say whether he was symptomatic, but beta blocker and ACE inhibitor, how many? Beta blocker, ACE inhibitor, and spironolactone. Okay, a lot of you didn't raise your hand, and I'm going to say that that's not really an option because you're seeing him in clinic. You don't really have an option of not choosing one of these, because if you don't do anything, well, it's A. So it's an important thing to remember when we're thinking about this. So obviously this is opening Pandora's box, because once you get to, say, Entresto, you might say, oh, well, it's too expensive and we don't have data. Okay, but you're starting to get to all these things. Once you think according to some logic, are you committed to following through on that logic? The answer is probably not. We don't generally do that. But if you do, then you're really opening a Pandora's box. So what's the neurohormonal paradigm? And this is briefly, there is neurohormonal activation, elevation of various circulating molecules and sympathetic tone in patients with heart failure, and that's historically been considered appropriate and beneficial compensation for low output, venous congestion, et cetera. So there's increased catecholamines, which increase inotropy, renin-angiotensin aldosterone, enhances blood pressure. But as we know, studies consistently have demonstrated that augmenting that response often causes harm, and interventions to blunt that activation provide strong benefits in cardiac function, symptoms, and mortality. So hydralazine doesn't blunt neurohormonal activation, but vasodilates and is helpful, while ACE inhibitors and ARBs, which vasodilate and block neurohormonal activation, are more helpful. Beta blockers, aldosterone inhibitors, et cetera. So how does this apply to ACHD? So we want to know whether neurohormonal activation is similar. Is the mechanism the same? And the answer to both of those is probably pretty similar. But then we want to know, do ACHD patients suffer similar bad outcomes? Meaning, if they're dying of different things, then maybe it wouldn't be helpful. Is the risk for adverse events due to underlying heart disease similar? As we've seen, the answer is definitely no. So the risks may be the same, but the benefits may be less. And is the risk for adverse events due to medications similar? And we'll really only talk about one, but all these have to be addressed before answering that question confidently. And I think ACHD is a great field for providers with borderline personality disorder. As we've seen, we really are splitters, right? And I'm not going to go through this. Karen did a great job of listing various lesions, but clearly there is a lot of distinction in our patients. And how do we split? Well, we're very proud that our patients are so diverse. Each is unique. And that leads us to focus on the differences between patients, which are there. And as we can see from the talks before, and in general, our primary thought is anatomy, to classify by anatomy, and then pathophysiologic modifications, and then we talk about how the patient's doing. So a patient with tetralogy of Fallot, with branch pulmonary stenosis and pulmonary hypertension, who's functional class 1. So that's the way we would generally present it and think about it. But the patient probably thinks, hey, I'm a patient who feels great, or I'm a patient who doesn't feel well, I'm totally healthy, and then their diagnosis comes later. So I think our fundamental bias is that our training focuses on anatomy and structure, and that's why our patients and we are different from our colleagues, right? And this is an inheritance from pediatric cardiology as well, where it's a paradigm that's worked very well. And this has led us to generally assume a benefit of structural interventions that, without any controversy, despite tenuous surrogates. So we're pretty confident that PVR for pulmonary regurgitation, just based on RV volumes getting better or not, that's good enough, and we accept that, right? Even Barry aneurysm screening for cork, not exactly the same thing, but it's something you can see. We know it's higher, but we have no idea that screening helps our patients, and all of us who have done this know it's a real pain in the behind and causes a lot of anxiety. But that was a guideline recommendation, while screening for kidney disease, which probably has more evidence, is not so clearly a recommendation. So we're more skeptical of probabilistic interventions, but we tend to shy away from any catastrophic risk, even if we could make an argument that there may be greater cumulative harm to doing something. So an ICD for primary prevention in just about any diagnosis in congenital heart disease is an example. So we don't have good evidence that it's helpful. And we sort of moved a little bit away from this, but how many times have you said to yourself or a patient or someone said to you, let's be conservative and put in an ICD? It's not conservative when overall the risk is higher, even if the risk is not sudden death. And we're really skeptical of accepting the applicability. We're nihilists when it comes to our patients when we think about medications which have long-term benefit and safety in larger populations, right? So I don't think you're a therapeutic nihilist, anyone here, when it comes to other things without great evidence in our population. If we can see a benefit in terms of structure or function, even if we don't know that overall the patients get better in a trial basis. Pulmonary vasodilators and Eisenmenger syndrome. Very reasonably, our field was worried about causing systemic vasodilation, and we didn't think it would be applicable. We got evidence that it was. Direct oral anticoagulants in Fontan circulation are similar. We tend to have a response that, hey, we don't know that their metabolism is similar to other patients. That may be true, but there are a lot of patients with liver disease and kidney disease in the adult AFib population that no one really has the same discussion about. So the things that make them different in the last situation isn't their congenital heart disease per se. Anyhow, I think that this is a bias we have to be aware of when we're thinking about this. It doesn't necessarily make our decision for us. So as was shown previously, neurohormonal activation is present in adult congenital heart disease. That, the same study that was shown earlier. What isn't usually mentioned is that in that study, it was pretty small, but there were 4 diagnostic groups, and there wasn't a real relationship between neurohormonal activation and what diagnosis patients had. There probably is some relationship, but it's not as strong in any population or any groups as the relationship between that neurohormonal activation and patient functional class and ventricular function. So a patient with a VSD, which has been closed, who has left heart failure and is functional class 3 or 4, has higher neurohormones than a patient with a Fontan circulation who is doing great. And the prognosis over the short to medium term for any patient is much more strongly related to measures of function than to anatomy or underlying pathophysiology. Again, while long-term it may be that a patient with a Fontan or a systemic RV has worse outcomes than any patient on average with an ASD or a VSD, if that first patient comes to you who's doing great and has good exercise capacity, they have a better 6-month or 1-year or 2-year prognosis than a patient with a VSD and bad ventricular function. And the same holds for neurohormonal activation. This is perhaps the strongest argument in favor of applying evidence from acquired HFrEF to ACHD. But the big caveat is that heart failure with preserved and reduced ejection fraction both have similar symptoms, similar adverse outcomes, and neurohormonal activation, although to differing degrees, yet most interventions effective for reduced ejection fraction haven't demonstrated benefit in preserved ejection fraction. The same is true for pulmonary arterial hypertension. Same neurohormonal activation. It's not because of the heart, but needless to say, the interventions would be different. So there are a lot of possible reasons for that chasm I won't get into, but one is heterogeneity. And heart failure with reduced ejection fraction is defined on symptoms, clinical syndrome, and some positive findings. So even if the underlying cause differs, which it does, there's somewhat of a common target. While HFpEF, you have symptoms of clinical syndrome and some normal findings. So there are a bunch of different reasons for that, including you're misdiagnosing the patient. They might have pulmonary arterial hypertension or lung disease. COPD causes edema, and maybe medications causing volume retention. So that's part of the issue. And there are lots of reasons for heart failure and CHD. I won't go into this as Karen has. And the question becomes then, how do we decide which ACHD patients fit that neurohormonal paradigm? And it's a bigger question of how can we identify truly meaningful patterns of disease in the messy soup of ACHD. We tend to do it with anatomy and maybe pathophysiology, but it doesn't often really work that well. So I'm just going to take a study from the HFpEF literature. This is a machine learning artificial intelligence project where they took a study of hundreds of patients well phenotyped in Chicago and looked at a whole bunch of clinical variables. Here we have some EKG variables, GFR, heart rate, age, sex, potassium, and this is above or below the mean value, standard deviations. This is patient here, and you can sort of hallucinate here as three groups that cluster, right? Instead of my hallucination, they actually did some quantitative nonsense and decided that three groups was appropriate. And what they found is three groups: one which was young that had normal BMP, a second one which was obese with diabetes, and a third which was older with much worse renal dysfunction. And that's kind of what we see in the general world, but this highlights that it might not be one diagnosis, and perhaps we can do a similar thing with congenital heart disease. The big caveat is that heart failure begins at birth for our patients and at an index event for HFpEF or other heart failure, so it's much harder to define when you're supposed to phenotype these patients to classify them. So back to Mr. Wright. So the RV is not the same as we know, and my mother told me, when in doubt, listen to Janis Joplin, and she did this: don't go looking for Mr. Right, go looking for Mr. Right now. Good advice. And the real question is it similar enough? We don't need perfect. How are we going to move forward and make that decision in clinical practice, right? Because we have to make that decision. Ideal would be evidence, but you're never going to get it. So these are valiant efforts, and it's important for reasons both from sample size, but also, as you'll see in a second, other reasons. We're really never going to get the data that we really need to make these decisions. It doesn't mean we can't make the decisions. Identify thought leaders and create guidelines. I'm going to move quickly through this. So this is similar to what most have said. The guidelines in these patients are non-existent. You have to be guided by general principles. One main principle is that a morphologic systemic left ventricle might be reasonably be subject to guidelines developed for those with acquired heart disease. Second is that there are no good guidelines for the other patients, okay? And at least that's humble and that's very appropriate, but we still have to make that decision for our patient, and a decision of omission is still a decision. So what about shared decision making? Dr. Mulder's not going to like me now. All right, so I always found this, there are two major challenges for shared decision-making. First, involving patients requires interpersonal skills, underpinned by a positive attitude towards the concept, and we have that, right? But it also, it means portraying options, and it requires knowledge about the existence of the legitimate choices and access to technical information about the associated harms and benefits. So speaking with a patient about sodium restrictions, saying, if you eat salt, you'll be happy. If you don't eat salt, you probably will be more likely to need less diuretic and not come into the hospital with heart failure, and there may even be some other adverse effects over time, but that's a shared decision, right? But if we can only provide vague hypotheticals, the patient really can't be meaningful involved any more than we can be meaningfully involved in the decision. So it doesn't really help us, except if we put the burden on someone else. What about N of 1 experiments? Why not try a given intervention and see if it works? We do it all the time. Diuretics, oxygen treatment of blood pressure. I had one patient with a mustard with an EF of 25% and bad heart failure, put him on an ACE inhibitor, boom, he diuresed and EF improved. That happens. What about coarctation? We don't have a debate. We should treat hypertension, right? Does anyone disagree with that? Okay. Do we have data that doing that provides similar benefit? No. We do know a little bit about pathophysiologic effects in coarc, but that's not what we care about. We care about clinical outcomes, and there are a lot of heart failure medications that in trials have not shown benefit even though they lower blood pressure. But we often use those neurohormonal modulators without questioning it. And the main difference is a robust, easily measured surrogate outcome, blood pressure. Like LDL, it's a very strong surrogate marker, and if it goes down, it's very hard to argue that it's unlikely that it's not helping that patient. But we don't know that. So how do we come up with robust surrogate outcomes? So surrogate endpoint isn't the same thing as a strong correlate. It should effectively substitute for the clinical outcome with effects of an intervention on the surrogate reliably predicting the effect on clinical outcome. So if an intervention improves RVEF, we should assume that that means it will improve outcomes. So which of these is a reasonable surrogate for clinical outcomes in ACHD heart failure? Now, needless to say, it'll vary from diagnosis to diagnosis. But I think all of these seemed reasonable to me. But amazingly, in HFrEF, the group that has good data, some agents improve exercise performance, like milrinone, but larger trials have not supported overall benefit for various reasons. Some don't consistently increase peak VO2, like beta blockers, but they're obviously beneficial. ICDs obviously don't improve VO2. And more amazing that there's really not much of a relationship between an intervention's effect on peak VO2 and its effect on mortality and systolic heart failure. There's some caveats to this, but it's somewhat impressive. And all these are exactly the same peak VO2 changes we see in all the studies we do, right around 2. And we're almost done. What about patient-reported outcome measures? That's appealing. So a patient's sense of status often corresponds to benefit of harm, and it's intrinsically meaningful. Even if something's not helping you live longer, if you're feeling better, that's great, right? But some interventions that improve outcomes cause a shorter long-term decline in a patient's sense of wellness, like ICDs or warfarin in certain situations. And that's okay when we can tell the patient, we can balance that against known benefits and risks. We say, yeah, you might feel a little tired from warfarin, you might be upset about taking medication, but here's the reason you're taking it. Without validation against clinical outcomes over long-term follow-up, patient-related outcome measurements can't really deliver for the many patients whose goal, most patients I'd say, who would say, yeah, I want to feel better, but really just make me live longer without developing heart failure. If that's what they want, then patient-reported measures are not, without long-term validation, going to be useful. So in the end, I think we're left, as has been highlighted before, we have to make a difficult decision with inadequate information integrating disease, intervention, patient and system factors. And I think the one thing we don't do as well is with insight into our biases and assumptions. To be very clear, people come to being a therapeutic nihilist not just through logic and it's through experience and probably seeing things don't work. So we have to be careful not to throw out our biases because some of them probably come for good reason, even if we can't express them. My mother would be very upset with me, but if Janice fails, I go to George W. Bush, and my job is a decision-making job, and as a result, I make a lot of decisions. All right, thank you.
Thanks, Sasha. The audience has been very quiet. Any questions for Sasha? Thank you for, that was a very thoughtful and I think very philosophic talk, actually. Anybody want to challenge the philosophy? Excellent.
Hi, Sasha. Thanks for this great talk. Now back to Mr. Wright. So how actually treated you him and why? What was the decision with Mr. Wright?
So in that situation, I think there's no right answer. I think that a lot of us would do different things as we see. I think my sense is that I look for an excuse, as Karen does. So we presented some data on albumin creatinine ratio in the urine and adult congenital heart disease and biventricular circulations. It seems to be predictive. Now, there's no data that treating that with ACE inhibitors helps in the general population, but it is a risk factor. So we sometimes will look for that, and that will be an excuse to start an ACE inhibitor. I do talk to the patients, not exactly shared decision-making, but explain to them that here would be our reasons for starting and stopping it. Often patients still don't really have a strong opinion, as I don't. I don't tell them to make the decision, but I explain that to them. It's a little different than shared decision-making. But I tend to, I think, in a patient with an EF of 30%, I would tend to want to have them on an ACE inhibitor if they could tolerate it, again, not if they don't. If they're symptomatic, yes, and if they have adverse outcomes or are very strongly opposed to medications, no. But it's just integrating all of that. So there's not one clear answer, but yes, I would tend to start it and not be totally nihilistic.
Okay, thanks.
And one of the things I would also then add a beta blocker, which I think is a little more controversial, simply because, again, I think logic would say that you probably do the same thing if they feel worse. That's that. I think that we don't have great evidence that even if, say, in L transposition, they have a higher risk of heart block. I've not seen evidence that putting someone on a beta blocker makes that risk higher. It is possible, but I've not seen. Have people seen people develop heart block just after starting a beta blocker in that population? No. I mean, that's always a worry, but I think that that's more theoretical, and who knows, could it decrease the risk over time? That's as much a nonsense philosophical idea, but it's possible.
Sasha, you've rightly kind of glossed over the definition of heart failure, which can be many things to many people. But I think the definition probably has some combination of symptoms and myocardial dysfunction. Barbara's talked a lot about focusing medical therapy on patients with symptoms. And do you agree with that? Do you think there's a way of sorting out symptoms that are due to myocardial dysfunction? And should we be focusing on them? Or are we talking about patients with symptoms of any kind that might represent heart failure? Is there a thought you have there for?
Well, there are a few different reasons to focus on patients with symptoms. One is that you're more likely to see an effect that you can actually appreciate. So the patient who came in, and actually I started him on Lasix, he diuresed a little bit, started him on low-dose ACE inhibitor, and he just lost 20 pounds and felt tons better. That's uncommon, but if that happens, that tells you something very clearly. You have the potential, you are likely to have a greater benefit in patients with symptoms simply because they have higher risk, do probably have higher risk. So when you don't know and you think there probably is a small benefit, when your event rate is 1% per year, the risk is substantially higher relative to that, while if your risk is 10% per year, a symptomatic patient is more likely to gain benefit. Some preliminary evidence may suggest that, again, there actually is true benefit that's different in the two groups, but I think that's going to be difficult to really show. You're right that trying to identify which patients would benefit would be the ideal, and whether that's just ejection fraction or other ways to do it. Ejection fraction is probably our best way at this point, but yeah, that would be ideal.
Thanks, Sasha.
Thanks.